It's really a pleasure to be here today, and I'm tremendously grateful for the opportunity to work with Dr. Haynes and with Dr. Tawari and his team. We've really developed a very robust and comprehensive interdisciplinary team focused on really the clinical and research side of all things prostate cancer. So today I'm going to be sharing with you some of the imaging perspectives and a little bit about how imaging fits into the program here at Mount Sinai. So as we know, multi-parametric MRI is playing an increasingly important role for the detection, the staging, and the localization of prostate cancer patients. MRI does offer the potential to improve patient risk stratification, to enhance patient counseling regarding various treatment options, and to assist in identifying patients who would be ideal for active surveillance. MRI can achieve a positive predictive value of up to 93% and a negative predictive value of up to 95%. So this is a very promising and very accurate tool. So in the context of our practice here, clinically this is a very busy urology practice who perform approximately 350 prostatectomies per year, and so we get both the imaging and the pathology sides of this. We see patients who are coming for a variety of indications for MRI, and these include elevated PSA, a strong family history of prostate cancer, palpable abnormality, or patients who have had a previously positive biopsy who are presenting for staging. We can follow patients longitudinally who are being followed with active surveillance and can perform advanced imaging in patients who have had prostatectomy to evaluate for recurrence. So just a word about our protocol. In order to generate really high quality images, it really does require an interplay between the patient, the protocol, and the interpretation side of things. So first we need to properly select the patients. Patients must be able to cooperate with the exams. They need to be able to hold their breath and avoid any unnecessary motion. Any concerns regarding claustrophobia need to be addressed ahead of the time. Patient education and technologist interaction with the patient are really essential. As long as the patients know what to expect, they tend to do better. And there are a variety of considerations regarding the high field strength systems that we're using that need to be taken into considerations when planning the schedule. And these include hip prostheses or other implanted devices or stents. So at the outset, it's important that patients come to the department with their clinical history. We need to know, as the radiologist, what the granular details are of the patient's presentation, what relevant biopsy information is available, any history of prior therapy. And this is all very important to the interpretation, and really we can't do our job if we don't have this information available to us. So I only include this slide just to kind of give you a sense of how the patients are prepared to have their exam. There are dietary restrictions that go into place. Patients have an enema prior to the exam, and we really kind of explain to them what to expect when they arrive in our department. So this is an example of our prostate cancer imaging protocol. And we'll talk in detail about the specific sequences, but the main driver sequence are going to be your multiplanar T2 weighted imaging, the diffusion weighted imaging, and the dynamic contrast enhanced imaging. The protocol in and of itself takes about 45 minutes. So this is an example of a T2 weighted image delineating the prostate anatomy. The transition zone or central gland is shown with the yellow arrow. The peripheral zone is shown at the periphery. How do I do the arrow? Okay, anyway. Okay, great. So the transition zone is shown centrally on this axial T2 weighted image. Here it is again on the coronal. The peripheral zone is on the outside of the prostate. On the coronal image, you can see the seminal vesicles coming in. As men get older, obviously the BPH becomes more of an issue, so the transition zone enlarges. As men also become older, the peripheral zone becomes increasingly bright or white on these T2 weighted images, which is very helpful because prostate cancers tend to be dark. So that helps with the conspicuity of detecting the lesions. So we perform our standard routine clinical imaging on a 3 Tesla system. The benefit of doing this is that there's higher signal-to-noise ratio, enabling improved image quality. We can scan with a shorter amount of time. However, there are some limitations to the use of a 3C system, and these include the fact that any artifact, if present, will always be worse at the higher field strength. Our current imaging protocols are all performed on a 3T system with the exception when patients have prostheses. So the evaluation of prostate cancer with MRI is a multi-parametric MRI, which means that we're using a combination of both anatomic and functional sequences to make our diagnosis. The T2 weighted imaging is an anatomic sequence. It gives us information about tissue morphology. The diffusion weighted imaging, we'll talk in greater detail about it, is a functional sequence which essentially assesses the mobility of water protons within a tissue. And the dynamic contrast enhanced MRI assesses tissue vascularity and perfusion. So in isolation, the T2 and the diffusion, or the T2 and the DCE, are pretty sensitive and pretty specific, but as we'll see, it's the combination of these sequences together that yields the greatest sensitivity and specificity. So why do we need functional MRI? Because T2 is limited in its accuracy. In isolation, T2 is about 60 to 70% accurate for detecting and diagnosing prostate cancer lesions. We need to be able to detect these lesions before focal therapy. We need to be able to provide information about pathologic grade and potentially predict and follow response after treatment. So for diffusion-weighted imaging, as I said, it essentially evaluates or probes the diffusion or the movement of water molecules within a biologic tissue. And this is done using a non-contrast, non-invasive sequence. It takes about 5 minutes, and we can characterize lesions based on their behavior over a range of B-values. And what is a B-value? A B-value essentially reflects the strength of the diffusion weighting, such that prostate cancers will remain hyperintense on high B-value diffusion, whereas benign tissue will be darker on high B-value, and we can derive the apparent diffusion coefficient, which is taken from fitting of the signal intensity to decay curves on the diffusion source images, and it gives us a metric value. And the lower the ADC value corresponds to tumor tissue, and the lower that value tends to, as I'll talk about in future slides, does correlate with tumor aggressiveness. So the combination of T2 to diffusion does really improve tumor detection. And as I mentioned, the lower the ADC value is noted in both prostate cancer compared to both normal peripheral zone and central gland. And this does have a potential role in active surveillance. So this is an example of how prostate cancers can be detected using diffusion-weighted imaging. This was taken from a recent study that we published in JMRI last year. We looked at the ability to use calculated high B-value diffusion weighting. This is the B1000. As you can see on the higher B values, the lesions become much more conspicuous. So the lesion's kind of seen here in contrast to the background peripheral zone, but on the B2000 image, it's very clearly identified. The tumor represents the bright areas. And this is what the corresponding findings look like on the T2. The lesions are T2 dark, they're well circumscribed. So this is a patient with bilateral cancer. So DCE, the dynamic contrast enhancement using the injection of contrast, is another promising technique for prostate cancer characterization. There are different contrast dynamics for both contrast for prostate cancers and non-tumoral tissue. There have been the derivation of advanced metrics using pharmacokinetic modeling to try to evaluate prostate cancer aggressiveness. However, there are some varying results and conflicting results with DCE MRI. Sorry, this keeps skipping. And there's really currently no clear consensus on a standard acquisition protocol or method to which we should analyze these images. So DCE is important. We find it clinically to be very useful. It's almost a fail-safe way for detecting cancers, but in terms of all the sequences we're looking at, it does play more of a minor role. So the cancers tend to be more hypervascular, and they have increased blood flow and distribution compared to the background tissue. And as I alluded to earlier, we feel that the DCE, and has been shown previously, does improve staging performance for less experienced readers. This is an example of a parametric map derived from a DCE, from a contrast image. You can see that there's a K-trans map. The K-trans reflects essentially the leakiness of the capillary vessels, and the VE map essentially reflects the volume of the interstitial space, and both of those findings do correspond to areas of prostate cancer that was shown at prostatectomy and are delineated by the blue arrows. So the American College of Radiology has set forth the PI-RADS, which is the Prostate Imaging and Reporting System, with the overarching theme to establish uniform technical parameters to guide image reporting and interpretation to try to minimize subjectivity, to really standardize communication and facilitate reproducibility and comparability across centers. And as I've mentioned, really the essential sequences are the diffusion, the T2, and the DCE. And they've recently updated it within the last couple years and have derived different algorithms for both peripheral zone and transition zone lesions. So the purpose of the PI-RADS is really to convey the likelihood of a clinically significant cancer being present. A PI-RADS score of 1 conveys a very low probability. A PI-RADS score of 5 conveys a very high probability. And as I mentioned, there are different assessment categories using the peripheral zone and the transition zone. The takeaway from this busy slide is that the diffusion-weighted imaging is really the cornerstone for the peripheral zone lesions, whereas the driving sequence for transition zone lesions happens to be the T2 weighted sequence. So we integrate the findings noted at the T2, the diffusion, and the contrast in order to derive our final PI-RADS category, which is shown here, and that final numeric value conveys the likelihood of clinically significant cancer being present. So we can also evaluate for ECE, because another important part of our job is to try to stage the patients. And we can convey the probability of extracapsular extension being present by correlating imaging descriptors with a numeric score. So there are several advantages to the use of PI-RADS. It does provide an algorithm for deriving an overall assessment based on individual scores, which is an improvement from the last PI-RADS version, has really simplified interpretation and has reduced the gap in performance between radiologists and centers. However, it is plagued by the inconsistent or suboptimal clinical use, the ambiguity and uncertainty associated with some aspects of the criteria that what I consider to be moderately hypotense and well circumscribed may be different from what a colleague thinks. And an important disadvantage is that clinicians should not make management decisions based solely on assessment categories, that it's really the integration of all the clinical, the imaging, and the path information that should drive that. So how good is PI-RADS for identifying clinically significant cancers? So you can see it's very, very good. For lesions that were classified as a PI-RADS 5, which is, again, conveyed a very high risk of clinically significant cancer being present, about 90% of those patients do have clinically significant cancer at pathology. Another note is that MRI lesion volume is impacted in prostate cancer detection rates. Obviously, that the larger the lesion, the more able we are as radiologists to detect these lesions. So let's review some clinical cases because we're all visually oriented. So this is a PI-RADS 3 lesion. It is moderately hypointense on the T2 weighted image. It's mildly hyperintense on the high B value diffusion weighted image, and it's mildly hypointense on the ADC map. This patient did have a 3+3 cancer and went on to prostatectomy. This is an example of a PI-RADS 4 lesion. What sets apart a 3 from a 4 is that the diffusion signal will be higher. It will be more markedly hyperintense. This is the high B value diffusion. It's avidly enhancing, and it's hypointense on the ADC map. So this was a higher grade cancer. It was a 4+3 at prostatectomy. So this is a PI-RADS 5 lesion. Again, this conveys the highest probability of clinically significant disease being present. There is a large cancer in the left peripheral zone. It is restricting diffusion. It is very low on the ADC map, and it is avidly enhancing. So this patient did have a 3+4 tumor pathology, and focal ECE was present. So this is an example of, sorry, this one's not projecting very well, but this is an example of a patient with multiple tumors. There are bilateral peripheral zone lesions. You can see that they're very, very bright on the high B value, and they're very dark on the ADC map. So it's really this diffusion, again, for the peripheral zone that drives the detection and the characterization of these lesions. So diffuse infiltrative tumor can be tricky. But this is a patient, an example of a patient who had diffuse infiltrative tumor throughout the peripheral zone bilaterally. You can see that the tumor is restricting, which means that it is very bright on the high B value. It is dark at the ADC map. This patient had extensive tumor without extracapsular extension. So we can use this for staging. MRI can be very valuable for helping stage the cancer patients. This is a patient, unfortunately the T2 isn't projecting well, but we really carefully assess the pseudocapsule to look for disruption in the pseudocapsule, to look for extension of tumor into the periprostatic fat. There was irregularity and bulging here, so this was called as concerning, and focal ECE was found at prostatectomy. So this is another example of a case in which there is a large peripheral zone tumor. There is measurable prostatic disease that is extending into the periprostatic fat at the margin. And you can see that there is irregularity and nodularity with extension. And this is a companion case which also shows clearly that the prostate pseudocapsule is disrupted. There is measurable disease extending into the left periprostatic fat, and this is in a separate patient. So transition zone cancers can be a little bit tricky, and there can be concurrent extension of tumor to involve both the transition zone and the peripheral zone simultaneously. So this is an example of a patient with a very advanced prostate cancer involving both the transition zone and the peripheral zone. The large tumor does avidly enhance. This is the DCE sequence. It is very bright on the diffusion, and it is very dark on the ADC map. So this is a very large tumor involving both compartments within the prostate gland. And this is the same patient a little bit higher up in the pelvis. You can see that there are metastatic lymph nodes. This is along the right iliac chain, the left iliac chain, and in the perirectal fat as well. So this is a separate patient who also has very locally advanced disease and has seminal vesicle invasion. You can see that there is diffuse involvement throughout the peripheral zone on the T2 weighted image. The entire gland is dark on the ADC map. There's avid enhancement throughout the gland, and on the axial and on the coronal T2 weighted images, there is direct tumor extension extending into the base of the seminal vesicles. So anterior tumors are a circumstance that the radiologist can be very helpful, because these can easily be missed, be it with a standard Truce biopsy or with standard clinical physical exam. However, we as radiologists can see the anterior tissue pretty well. There's a large cancer involving the anterior transition zone, which is extending into the right anterior fibromuscular stroma, and metastatic lymphadenopathy was noted on the diffusion weighted imaging and on the T2 weighted imaging. So multi-parametric MRI does have other areas of added value. As I noted, that the anterior location can be tricky, as can the apex. So this is a patient who had multiple negative biopsies and a persistently elevated PSA. There was great concern that this patient had a prostate cancer, but we weren't able to find it. The patient came to MRI, and we can see that there is a lesion in the right apex that is restricting diffusion, and it is dark on the ADC map. We were able to inform the clinician about this. A targeted biopsy was performed, and the diagnosis was made. And as I alluded to earlier in the previous case with a transition zone cancer with metastatic lymphadenopathy, that anterior fibromuscular stroma can be very difficult to evaluate clinically. So there is, again, in this case, a separate lesion in the anterior stroma. It is avidly enhancing, and it's restricting diffusion. So as I mentioned earlier, the ADC value can be used to essentially predict tumor aggressiveness, and there has been variable correlation, inverse correlation with the ADC value and Gleason score. And this is believed to be due to the higher cellularity within higher grade tumors. So ADC and advanced ADC methods, which I'll talk about in future slides, do have a lot of value in possibly predicting tumor aggressiveness. So furthermore, additional added value for prostate cancer includes for the evaluation of the post-prostatectomy state. This is a patient who came in for persistently elevated PSA, who'd had a prostatectomy. On the sagittal T2 weighted image, there's a mass in the surgical bed anterior to the bladder. The mass demonstrated restricted diffusion and was avidly enhancing, so the area of tumor recurrence was localized. And this is a similar patient. Unfortunately, the T2 isn't projecting, in which the patient had been treated with radiation therapy, but on the diffusion-weighted image within the treated prostate, we were able to discriminate the recurrent tumor compared to the background prostate tissue. There are some pitfalls. MRI is not perfect. When in the post-biopsy setting, there often is substantial hemorrhage within the peripheral zone, which can confound not only detection but characterization, because the diffusion sequence can be affected by the presence of hemosiderin from the hemorrhage. This was a case that there was a very large cancer in the small cancer actually in the left peripheral zone, but on the right peripheral zone, this whole T2 dark area actually corresponds to this area of hemorrhage on the T1 weighted image. So unfortunately, this case was misinterpreted. There was concern that there was extraprostatic extension of disease into the right periprostatic fat, which was actually just a little bit of inflammation following biopsy, whereas the tumor was localized on the right. So the post-biopsy setting can be tricky and confound interpretation. The presence of BPH nodules can have a significant overlap in appearance with transition zone cancers, which can make it challenging to make the distinction. However, key features that can help discriminate a BPH nodule from a transition zone cancer on imaging include the fact that TZ cancers tend to be lower in ADC compared to a BPH nodule. They tend to stand out on the high B-value diffusion-weighted imaging compared to BPH nodules, and they have a very distinctive appearance on T2. It's called erased charcoal. It's smudgy, T2 hypointense. So there are some features that can be used to discriminate the TZ cancers from stromal BPH nodules. This was an example of a patient with extensive prostatitis. The patient had a lesion in the left peripheral zone at the base of the prostate. It looked like there was mass-like extension into the left seminal vesicle. So there was concern for very extensive disease. The patient underwent biopsy, and this turned out actually to be only prostatitis, so this was a false positive. So this is another really great example, actually, because this is a patient who has a discrete, well-circumscribed lesion in the left peripheral zone. It's avidly enhancing. It's restricting diffusion. So it fits all the criteria for a PI-RADS 4 lesion, which conveys a high likelihood of clinically significant cancer being present. The patient had a targeted biopsy. Focal prostatitis was found. The patient underwent repeat imaging about a year later, and the lesion had completely resolved. So that was an example of a false positive. So apex lesions can be missed despite the added value of MRI in detecting them, and that's where really having that dynamic contrast enhanced image to kind of catch you as an extra sequence just to make sure you don't make any mistakes can be of value. So the anterior fibromuscular stroma overlying the anterior prostate tends to be T2 dark, so it can be difficult to find the lesions, as cancers are T2 dark as well, but the dynamic contrast enhanced imaging clearly helps the lesions stand out. So as I mentioned before, technique is very important. Patients who have hip prostheses are placed on the lower field strength clinical system because there is such significant distortion artifact on the diffusion weighted imaging from the hip prostheses that the sequence is non-diagnostic. So that essentially does limit to some extent the ability of MRI to detect these lesions. You know, rectal gas is another important thing which can affect image quality, which is why we give patients such detailed instructions prior to presenting to our department. Any gas within the rectum can cause anatomic distortion of the prostate on the diffusion-weighted imaging. So there have been several recent advances that we're excited about here at our department. We've looked at advanced diffusion methods. Can we look at using an advanced diffusion sequence that's shorter, that saves time with acceptable SNR? Is this as good as a conventional diffusion-weighted sequence for detecting and characterizing these prostate lesions? So we looked at comparing the standard trace diffusion to a diagonal diffusion-weighted sequence, which essentially just is a different acquisition method, but essentially is 30% shorter in time, so it's a pretty significant time savings. And we found that the newer diffusion sequence had similar acceptable SNR and essentially equivalent lesion detection rates. We can also look at advanced ways of modeling diffusion-weighted imaging for characterizing prostate cancer. This is a paper that's currently in press in radiology. Dr. Talley and his team looked at different diffusion metrics, different methods of diffusion-weighted imaging, including diffusion kurtosis, a stretched exponential, and diffusion tensor imaging, and correlated the metrics from imaging with advanced histopathology, and found that there were significant correlations, and that these advanced diffusion methods did provide additional information about the prostate tissue. And this is a current ongoing project, is looking at the use of an endorectal coil in addition with the 3T system that we're using currently. When prostate imaging was in its infancy, it was commonly used that an endorectal coil with an inflatable balloon was used on a 1.5T magnet. And then with the advent of the higher field strength systems, we had enough signal to noise that we could get away with just using a phased array coil, but now there's a renewed interest in using 3T imaging with an endorectal coil in place. So we currently have an ongoing study to compare image quality and lesion detection rates without and with the coil at a high field strength. So in conclusion, multi-parametric MRI is very valuable because it not only combines both morphologic and functional information for both prostate cancer localization and staging. Ultimately, it's the patient selection and the counseling and the optimized protocol that's really essential to generate high-quality images and a high-quality report. The integration of all the clinical, the laboratory, the pathologic, and the imaging data with knowledge of key important imaging pitfalls. And ultimately, these MR-based scoring systems do need to be validated in a prospective study with prostatectomy, and there are a variety of exciting new potential applications as well. So I would again like to thank Dr. Bashir Towley and Dr. Haynes and the rest of the team for the opportunity to be here today. Thank you.